Good morning, everybody. Good morning, everyone. Good morning, everyone. Could we ask everyone to please take their seat? We're about to begin our program. Thank you. Good morning. I want to begin by thanking each of you for participating and being part of the solution to the statewide opiate epidemic. The Partnership for a Drug-Free New Jersey and Horizon Foundation for New Jersey have embarked on a new 2-year Knock Out Opioid Abuse initiative to address the opiate epidemic through community outreach, prescriber education, parent education, and a statewide awareness campaign. This today represents the 7th of 21 Knock Out Opioid Abuse town hall meetings that will be held in one community in each one of New Jersey's 21 counties. It's now my pleasure to introduce the Chancellor for Civic Engagement for the Associate Chancellor for Civic Engagement for Rutgers University, Neema Watson, who is our host today.
Good morning, everyone. Thank you so much for being here today. On behalf of Chancellor Phoebe Haddon, we welcome you to our campus, and we really want to send a special thank you to the New Jersey Partnership for a Drug-Free America and the Horizon Foundation of New Jersey for allowing us to host and allowing us to partner on this event today. The health and spirit of our communities right now has really been gripped by the opioid crisis. And it's my hope for us today that as we leave here, we have a better understanding of how we can all work together in our families, in our communities, in our institutions, to not only quell the tide of this epidemic, but to create long-lasting change so that individuals have a better pathway to healing and support so that they can really deal with themselves and what led to their drug addictions, but that through healing, through support, it doesn't take over their lives. So thank you to all of our panelists and our community partners who are here today to share. And I want to send a special thank you. I worked with Matt on giving up some suggestions for people to speak today. But I have a special thank you to one of our students, Alexa Garvey, for being here and sharing her story. I heard Alexa speak at her graduation this past May. And as you know, when you put together graduations, you're getting speakers from all across the country and you're offering up honorary degrees. But I was so deeply moved by hearing her story, moved by her grace, her vulnerability, and her willingness to share of herself to help others make the transformation that she did. So thank you so much for that and for being here today. So welcome to campus, welcome to everyone who's here, and I really hope that we have some thoughtful conversation. Thank you.
There is not a question that New Jersey is in the midst of an opiate epidemic. There's not a day that goes by without hearing or seeing a story in our neighborhoods or in the media on the impact of the misuse of prescription medication, heroin abuse, the countless overdoses impacting all of our communities, and so many families dealing with the day-to-day challenges of the crisis and the disease of addiction. The Camden community is not immune. No family or community is immune, and today we gather to learn. We gather to learn how a community can address the epidemic, how individuals can make a difference in fighting this crisis, how we can prevent more New Jersey residents from becoming addicted, how we can reduce the stigma of addiction, how we can help those who are addicted, how we can support those in recovery, and how we could bring awareness to this crisis. Now, we know there's no easy answers to solving the opiate epidemic, but there's always ways each of us can make a difference in this important fight. It's necessary for everyone, parents, community leaders, students, and residents, to work together as a community and develop ways to end the epidemic, and more importantly, to change public attitudes towards addiction. This town hall and other efforts will empower and educate New Jersey residents about taking important steps to changing the stigma that is so often associated with this disease. And ultimately, we hope it will reduce and prevent opioid abuse here in the city of Camden, Camden County, and throughout the state of New Jersey. At this point in time, it's indeed a pleasure and an honor to introduce the partner for today's town hall, Horizon Blue Cross Blue Shield of New Jersey. And we have with us a board member from the Horizon Foundation for New Jersey, Luis Diaz, to make some presentations.
Good morning, ladies and gentlemen. It is indeed my pleasure to be here with you this morning to speak to you on behalf of Horizon and my fellow board members and the company in general, which very much is concerned about this issue. I'd like to welcome you to this important town hall on the response to the opioid epidemic. I want to thank you, Angelo, for your kind introduction, but more importantly, for your leadership. And thanks to all of you for your interest and for attendance at this important event. As the state's largest and most experienced health insurer, Horizon Blue Cross Blue Shield of New Jersey is dedicated to improving the lives of New Jersey residents. We are very proud of the Partnership for a Drug-Free New Jersey to bring you today this town hall meeting. It's part of a larger initiative, the Knock Out Opioid Abuse Town Hall Series, that is taking place in communities throughout the state through 2020. This collaboration is part of our company-wide focus to use all of our resources at our disposal to help end this public health crisis in towns in which we live and also work. The Town Hall Series and many other efforts are being funded through the Horizon Foundation of New Jersey, the philanthropic arm of our company, on which I am proud to serve. The grant to the partnership represents a large portion of the $1.3 million the Horizon Foundation has awarded in grants since 2016. Our goal has been to educate New Jersey residents about the seriousness of the opioid epidemic and what is being done to help address the substance abuse disorder. The crisis impacts every community. I just had the pleasure of speaking with Lucius Stringfeld, who educated me a little bit further about just how wide-reaching this disease is. It is truly an equal opportunity disease. It does not discriminate any community and any income and any location, so no one is exempt. In 2018 alone, 47,000 drug-related deaths occurred across the United States. New Jersey alone had more than 3,100 drug-related deaths. These are historic levels. And the alarm bells are ringing loud and clear. We need more people to become involved. People like you, to become part of this important solution and this important initiative. Through our collaboration with the partnership and other state and local nonprofit agencies, we are committed to using the Knock Out Opioid Abuse campaign to combat the opioid epidemic. There are many great organizations in this room today that are part of that effort, and we commend them for that. We will continue to do so through community outreach, prescriber education, parent education, and a statewide awareness of the campaign. And we will do so by being here at this level, at the grassroots with you, learning from people like Lucius, so that we can take that back to the board and to the company and be even more effective in our efforts. This morning, we are going to hear about the impact of opiates and this epidemic in your community and the steps that are being taken to address them. In closing, I want to thank Rutgers, my alma mater, for hosting us and for collaborating with us to present this town hall. I also want to thank all of the distinguished guests. These are thought leaders in this space that are going to be part of this panel for their participation and for taking the time on a Wednesday morning to come out to Camden to talk to you guys. Today, the Horizon Blue Cross Blue Shield Company is working with our partners and each of you so we can make a difference in combating this epidemic that is destroying lives and destroying families. On behalf of our board, on behalf of myself, I want to humbly thank you for the opportunity to speak to you. Thank you.
Thank you so much, Louis, for your leadership and the commitment of Horizon Blue Cross Blue Shield in New Jersey. And I just want to introduce Jen Gowdy and Jonathan Pearson, who are here with the Horizon Foundation, who have been working with the partnership and the partnerships team for the past several years on developing this town hall series and many other initiatives in the state. So let's give them a nice round of applause as well. It's now my pleasure to introduce to you a true partner in our efforts in the state of New Jersey and throughout the country. We have been working along with the Horizon Foundation with the New Jersey DEA for over 2 decades, and they have really been in a leadership and role not only in the state but throughout the country in their collaboration with the prevention community in New Jersey. It's now my pleasure to introduce Nick Cullen, who is the DEA representative from Camden.
All right, good morning, everybody. I know, hump day, Wednesday, Camden. Whew. All right, so I'm going to get into some things. I only have a few minutes, but I'm going to paint a picture for you. I know most of you are in this field where you're hearing daily about the effects of the opiate crisis we're in the midst of. And before I do, I'll just take one step back and tell you just briefly about myself. So I'm an assistant special agent in charge for DEA. And I've been with DEA now as a special agent for over 28 years. I've had a chance to live all over the world. I lived in Colombia and South America. And I've had a chance, I visited over 34 countries now. And I can tell you without a doubt, we are right now in the midst of the worst drug crisis our country has ever seen. It's hard to really fathom and really grasp it. So I oftentimes like to paint a picture. So before I get in too much, let me ask you, do we have any Eagles fans here? That's what I like to see. Bleed Eagle, like bleed green, right? I'm down with that. I'm originally from Philadelphia, family of 8 kids, so you know I grew up and I get the feeling of what the passion is. Just imagine though, you're at the Lincoln Financial Field. You're watching an Eagles game. We just get done beating the pants off somebody. Amen, brother. And so, end of the game, you're sitting there, and then all of a sudden you're looking around the stadium, and then bam, everyone in the stadium drops dead. The stadium holds 68,532 people. Last year, we lost over 72,000 Americans because of drug overdoses in this country. It's crazy. If you can imagine, everybody in that stadium, we lost that many last year, just last year. So it's hard to really fathom and grasp. People are dying, dropping dead, left and right, every day. People we know, friends, everybody's been affected by it anymore. And the scary thing is, we're now battling this opiate crisis. And I got to tell you, there's a lot of people in this room that have done a lot of great things to help make progress. And we are making progress. In 2015, I believe we had 5.6 million opiate scripts. We're down to 4.1 in 2018 of opiate scripts in New Jersey that were handed out by doctors, by prescribers. That's great progress. But unfortunately, we're not making the progress we all hoped. Because unfortunately, in 2015, we had over 1,500 deaths, overdoses here in New Jersey. As you heard from a colleague from Blue Cross Blue Shield, last year, we had over 3,100 here in New Jersey. As of July of this year, we have over 1,600 overdose deaths here in New Jersey. We're on pace to pass last year here in New Jersey. So we got to ask ourselves, what's going on? How do we get a grip? How do we get a hold of this? There is no silver bullet. And really the best resource, Angelo, I really applaud you and the partnership for all you have done. And as he mentioned, DEA, we've been partnered to this for over 2 decades. We recognize this is going to call, this is everybody needs to stand up, jump in, both feet. Everybody needs to help out. Everybody needs to be part of the solution. Because really the game changer, what we're dealing with right now today, is something called synthetic opiates, fentanyl. You guys all hear of fentanyl? Who didn't, right? I just heard the Los Angeles, the California Angels pitcher just died, overdosed. Pills, fentanyl in the pills. Crazy. It hits everybody. No one's immune to it. So fentanyl right now is being put in everything. So in the United States, there's something called NFLIS, the National Forensic National Forensic Information Laboratory System. There's 288 laboratories across the country that all put their data into this. And one of the scary indicators, in 2013, there were 934 exhibits, that's drug exhibits, whether you buy drugs, you seize drugs at the border, you see someone in a car, you take drugs, you send it to the lab analyzes all these 288 labs, they send all the results into one place. So we had 934 exhibits in 2013 that had fentanyl on it. Last year, 2018, we had over 83,000. 83,000. So it's not that all of a sudden people are starting to use fentanyl. It's just that all the traffickers are putting fentanyl in everything. It's in everything. So it's in your heroin. All the prescription pills, over 50% of the pills now on the streets are not pharmaceutical grade. They're made in someone's basement. And it's crazy because they're not making, these aren't FDA approved chemists. They have a pill press machine, they're stamping these pills, they're mixing it up with a bucket, and they're putting the drugs into baggies. Some of them are hot batches. We see more often than not here in Camden, Cooper, they'll put out a public service announcement, like calling law enforcement, letting us know. Rash of overdoses, 10 overdoses, 10 or 15 overdoses, people dying, dropping dead. Why? Because there's fentanyl. Fentanyl's in the heroin. Fentanyl's in the coke. Fentanyl's in the meth. Fentanyl's in everything. And that's why we're seeing this epidemic we're in the midst of. So we got to figure out a way how we can get people to address the drug use. Because if they stop from fentanyl or from heroin, they're going to use coke. People are dying from coke with fentanyl in it. So this is a crazy time we're in the midst of. So 2 quick things before I conclude is DEA, we do have some resources for you. One, I'll say with me today is Special Agent Tim McMahon. He has what's called a mock bedroom. We do something called hidden in plain sight. That's what he's doing there. I encourage any parents, you guys have questions, what to look for in your kids' rooms. Tim will educate you to things you never imagined. But that's a sort of resource that we do. Tim travels around the state and puts that on in schools, high schools for parents. It's an education thing. We have Take Back, National Prescription Take Back, October 26th, 2 weeks from now. It's all over the place, police departments all over. Bring your drugs, any drugs, no questions asked. Go into grandma's house or medicine cabinet, wherever you got to go. Get these medicines out of the medicine cabinet, drop them off, no questions asked. We'll take them. All right? And lastly, a resource for all of you. It's something we have, really, we did a great job on this DEA. We partnered up with Discovery Education, and we have something called OperationPrevention.com. OperationPrevention.com. I encourage you all to look at it, check it out. Really great. It's intended for schools, for elementary, middle, high school, for parents toolkit, all kinds of cool stuff on there to get the real fact-based information that you don't have. So to conclude, DEA, we're here. We're here with partnership, Blue Cross Blue Shield. Thank you for help sponsoring this. Rutgers, Camden as well, thank you. DEA, we recognize we have to be part of the solution like all of you. So if you have any questions, I'll stick around. I'll be here today as well as Tim. And we look forward to working with all in your future. Thank you.
Thank you so much, Nick. And just for a bit of history, Nick mentioned about the Take Back program. Well, the Take Back program was created here in New Jersey between the Partnership for Drug-Free New Jersey and the DEA New Jersey. Way before it became a national Take Back Day, we were the first state in the nation to host a day of collection, and that was the role model that was used on a national basis. So we're very proud of our long-term relationship with the DEA and the work that's being done in the state. Today's town hall is just as much about learning from the experts as learning from each of you. We know that we are at the epicenter of this crisis in Camden, and we appreciate and welcome your comments and your suggestions as we go into the open session. We want you to know, and we want to know, how this epidemic is affecting each of you in everyday life, what's working in our community here and what's not. What we want to hear about questions and recommendations on what you'd like to see shared and implemented. In fact, each of you has been given a survey today to complete at the conclusion of today's town hall. The information you'll provide to us will help us understand how the opiate epidemic affects communities and how the partnership and Horizon can most positively impact those communities at future Knock Out Opioid Abuse town halls. We'd ask each of you to complete your survey at the conclusion, and when you complete your survey, you'll be entered into a drawing to win an Apple Watch courtesy of Horizon. So it's a great incentive, and we hope you'll all complete your survey. Just another bit of housekeeping. If you are parked in the parking garage, if you bring your program to the counter at the conclusion of the event at the parking garage in the lobby, they'll waive the parking fee for those that are parked in the parking lot. So it's now my pleasure to introduce and hear some opening comments from our panel. The first member of our panel is the Department of Emergency Medicine here at Cooper University Healthcare Center, and that's Dr. Matthew Salzman. Doctor? Our next panelist is Dr. Linda Muir, who is a Associate Vice President of Substance Abuse Disorders in the Center of Family Services. Dr. Muir. Our next panelist, Dr. Serena Natel, is from the Psychiatric Mental Health Nurse Practitioner. Dr. Natel. We're very pleased to have our next panelist, a person in long-term recovery, a graduate student here at Rutgers University, Alexa Garvey. Alexa. And finally, we welcome the senior pastor from Today Christian Church, Keith Davis. Okay. So we're going to begin today by asking Dr. Salzman a question. Doctor, could you discuss how the opiate epidemic, from a public health perspective, and what medical community is doing to address this issue?
Yeah, sure. So first of all, thank you for having me today. You've already heard some of the data that we have in terms of deaths from the overdose epidemic in which we find ourselves right now, right? And we have outpaced the AIDS epidemic from the late 80s, early 90s, and into the early 2000s with the number of deaths per day and number of deaths per year. If you want to put a dollar number on it, the current estimate is that the overall cost to society annually from the overdose epidemic is about $78 billion, and that's billion with a B, right? And that includes hospitalizations, fatalities, complications as a result of injection drug use, days lost to work, and a whole bunch of other things. So this is a huge impact economically. And we see the impact on families all of the time. I'm currently staffing the inpatient consult service at Cooper University Hospital. I'm one of the addiction medicine specialists as well. I can tell you to maybe make it a little bit more real, because $78 billion doesn't really sound like a real number, right? That's like, I can't even really wrap my head around that number. There are currently 39 patients on my consult service, and it's just me this week. I've got a couple great medical students who are stuck with me for the week. They're doing a great job. I would say that of those 39 patients, probably 35 of them have infectious complications as a result of injection drug use. I've got 2 patients who I'm trying to help who have infections in their heart. They've been struggling with injection drug use for years and years. They already had their valves replaced once surgically because they had infections, and because of whatever their barriers are to getting evidence-based care, they've continued to inject, and they have reinfected their now bioprosthetic valves. So what's that individual's cost to the healthcare system? $1 million, right? These patients are in the intensive care unit, getting antibiotics, getting other medications, and sometimes going to the OR to try to clear their infection and surgically, treat their infection, which is really important. The ethical question is, that I don't have a good answer for you, and it's not really what I'm here to talk about today, is when have we decided that the patients have reached the terminal stages of their disease and they're just simply not going to get better? And it's a question that I think we need to ask, and there's no clear answer for that. I would argue that all of these illnesses, all of these infections are preventable. And in full disclosure, I'm a very leftward-leaning person. I'm a harm reduction advocate to the end. I think that the decision that was recently made in Philadelphia to support a supervised consumption facility is a very important one. And this is part of stigma reduction, but it's also harm reduction, right? And so we can offer patients medications. I am a buprenorphine prescriber in clinic. The evidence to support medication-assisted treatment or pharmacotherapy or whatever you want to call it is robust, and it clearly works, but still some patients aren't ready. And we can reduce their disease burden by providing them with safe needles, safe injection practices, by carrying naloxone with us. Everything that we can do, because as some people like to say, you can't rehabilitate a dead person, right? So I know that the things that I tend to talk about tend to be very polarizing, and people have a lot of emotions and thoughts and feelings wrapped up in the disease of addiction. But as an academic center and as a clinician, I'm required to practice evidence-based medicine, right? And we wouldn't be having this town hall meeting about diabetes, right? There's no stigma around diabetes, right? People need insulin, they get their medication, hopefully they get better. We don't withhold medication or other treatments from them if they're non-adherent to their treatment plan. So I think that we can do a lot more work in terms of advocating for our patients for best practices. If a patient wants to retain in sobriety, with abstinence only, I think that's great if that's where the patient is. But we really need to increase access to evidence-based care, to medications for patients when they want them, and keep in mind that only about 1 out of 10 patients who struggle with opioid use disorder will remain sober on abstinence-based treatment. And so really, expanding access to buprenorphine, expanding access to methadone, getting rid of the X waiver, which I'm required to have in order to prescribe buprenorphine, allow primary care providers to prescribe not just buprenorphine, but also methadone in order to expand access to the approximately 1 million people in the United States who have no access to evidence-based care for opioid use disorder, are some of the things that we need to be doing, as well as advocating for additional harm reduction strategies throughout the country.
Thank you, Doctor. Our next question is for Dr. Muir. Has the opiate epidemic impacted Camden, and if so, what support services are available for the residents of this community?
So Camden was one of the original 5 counties in New Jersey that was recognized to be in such dire need of addressing the opioid use that when programs were rolled out to address the problems that are going on in emergency departments, the problems that are going on into getting people into treatment, Camden was one of the first 5 counties that was provided services, starting with a program called the Opioid Overdose Response Program. So for Center for Family Services, we provide that at every hospital in Camden County at this point, thanks to both state and county dollars. Camden County is quite unusual in providing significant funding to be going into the emergency departments, and we're really grateful for that. But that gives you an idea, I think, of the significance of Camden County in the story in New Jersey for opioid use, that it was one of the original 5. The others are in North Jersey. So for South Jersey, Camden County was really the epicenter for trying to address this right from the outset of about 2015, 2016. There are a variety of services at this point that are provided in the county. We have a number of them at Center for Family Services, but throughout the county, there is a range of choices for people to address the addiction that they have. There are not enough, as the doctor said. You can't get access quickly enough to medication-assisted treatment. That's probably one of the biggest backlogs that we wind up experiencing, is getting somebody who agrees that they want that form of treatment right from the outset, but getting them into treatment. There just aren't enough treatment centers, and there's not enough medication, and there aren't enough doctors prescribing. And that is where I think the field really needs to take a look at how it can expand services and access to services. But the problem with opioid use goes well beyond just getting medication to address the addiction. What we've seen over, so sitting in here are lots of reports that I pulled from our treatment end, because we provide both treatment and prevention services. And from the treatment end, when we took a look at, from about 2006, when the state began to collect data through its assessment and admission system called New Jersey SAMS, what you find is kind of a whack-a-mole of choices that people have made around the drugs that they use. Alcohol use, actually, in terms of people identifying it as their primary drug of choice over the period from 2006 through last year, has actually declined a little bit. The one that's really gone down significantly is cocaine use. It's less than half of what it once was in terms of people identifying cocaine as their primary drug. Needless to say, some other things have gone up. And the big one, of course, that's gone up and has more than doubled as the identified primary drug have been the opiates, going from about 16% in 2006 to well over 34% of clients who, when they enter treatment, identify it as their drug of choice. And as I said, it's not just accessing treatment. What we've seen at the same time is, bizarrely enough, in a world where we're told we have no unemployment, that we have full employment, of those who come into treatment, the number unemployed has actually risen, and the number who are employed has actually gone down. The number of people in need of housing when they come into treatment has gone up. The number of people who report that they live independently has gone down. The number of people who report that they have graduated college when they come into treatment has declined. The number of people who report that they have a high school education and that is where their education stopped has gone up. These are the folks who comprise largely those reporting opiates as their drug of choice. These are our construction workers. These are our first responders. These are people who are mechanics, who are being prescribed opiates across the board when they report to their physician that they need some help with pain. And so I think that that's why you're seeing the change in education level for those coming into treatment. So this is among the areas that people need assistance with. They need assistance with housing, they need assistance with employment and possibly workforce development to get reemployed so that they're not working in the same field that they developed their addiction in. They need help with their education, they need help with all kinds of social supports in addition to taking medication. Anybody who thinks that simply taking medication to solve an addiction is going to be left hanging when it comes to trying to get their life functionally back together. What the medication absolutely does is help people buy some time to get the skills that they need and the training that they need and the other social service supports that they need in order to get on with their life and get into recovery, however they define that recovery for themselves. And I'm totally with the doctor in terms of harm reduction, what's going on across the river. You know, we don't have all the answers. We didn't have all the answers for the crack epidemic. We don't have all the answers now, but we certainly know what the trends have been and what people's needs are. Center for Family Services, our executive offices are right across the street from Cooper Hospital, in fact. We remain committed to Camden City and to Camden County in terms of the services that are provided. Among them is a workforce development program that is recently federally funded called Rework. Several programs for family members and friends who have lost somebody. We have the state-funded Recovery Support Center in South Jersey. There are only 2 of these in the state. One is up in Patterson and the other is in Voorhees at our facility across from the old Echelon Mall, Voorhees Town Center. And all the services there are free of charge. Nobody will be charged for any support group that they come to, for using computers to do job searches, for talking with staff about getting legal records expunged. All of those services are completely free to the community. Not just Camden County, but throughout South Jersey, people can access this. So there's a variety of support services. There's a variety of treatment options for people. Not enough again, but they are out there. Cooper is on the forefront. There are programs that we participate in, one called MRAP for pregnant women. Cooper has a strong program for new moms, and I can't say enough about the number of services that are out there. But the problem is so pervasive that it's almost like you can't have enough services. People have talked about the dollar amount. It was mentioned the baseball stadium worth of people that are dying each year. One other way that I've heard it put is, imagine if the World Trade Center came down every year in New Jersey, because that is the number of people. And what was our reaction to the World Trade Center? Well, we need not to lose our energy about this, because that's the number of people who are dying each year just in New Jersey.
Thank you, Doctor. Our next question is for Dr. Natal. What type of hurdles exist when someone is seeking co-occurring treatment, and what can they do to get help?
Sure. Thank you for having me, by the way. So just to elaborate a little bit on what co-occurring treatment actually is, it's when we have someone who is suffering from both an addiction or a substance use disorder as well as a mental health disorder. And I think the first hurdle we see is recognizing and identifying that a mental health disorder actually exists. And once that identification is made or recognizing, then we can then put treatment in place, because treating just the substance use disorder itself without treating the mental health component will always leave us behind the 8 ball and back to the substance use disorder. It's kind of like a vicious cycle, sort of say. The second hurdle, I would say, is lack of knowledge on where to get treatment and how to get treatment. We've heard others say that we're low on providers or there's not enough providers, and for mental health providers, it's really, really bad. People wait 2, 3, 4 months, depending on their insurance, just to get an appointment with a psychiatric provider. So being able to access mental health services is a huge hurdle for someone with a co-occurring disorder. And then, as I said, if they can't treat that mental health, they're back in this cycle with the substance use, and it just perpetuates itself. Another hurdle is a shortage of treatment providers. So from whether it be a psychiatrist, a psychiatric nurse practitioner such as myself, or a mental health therapist or a psychologist, there's just not enough of us in New Jersey or all over per se, because these same waits we see in other states, not just here. And then I would say that last hurdle would be a lack of continuing care. So if we are treating people at a residential level for substance abuse or even in a hospital setting, we often find that they are started on, whether it be medication or some sort of therapy is started, but once that client leaves, having them be able to follow up is something that we just don't see happening enough. And then again, I'll repeat myself over and over, we see that cycle. I'm not treating my mental health, so I'm using more substances to blunt what I have not treated from a medication perspective or a therapy perspective. And when we talk about helping those things, I think one thing to know is that every county in New Jersey has a mental health administrator. Most of them are located in your county offices. So starting there and trying to figure out how you can find these services, the quickest way to get into service is very important. We often see even the ERs overutilized for mental health services, because that's the only place a client knows that they can go and get immediate treatment when they're trying to treat a co-occurring disorder. Another way is primary care. So primary care is often the first line of treatment for mental health. Most people don't know, if they've never had to access a psychiatric provider, that there are psychiatric providers out there. So they start at primary care, and primary care can treat and then refer. They are a great resource for getting clients into mental health treatment. And then I'd say that last thing to overcoming that hurdle is advocating on both a provider level and a client level to make sure that whatever that next level of care is, it involves mental health services. So for our clients on the outpatient level, advocating to receive mental health treatment, and for that client from a residential setting, advocating that their next level of care includes co-occurring treatment. So in the state of New Jersey, it's a requirement that all outpatient treatment centers have a psychiatric provider. But I often tell people, if there's not a body to put into place, that requirement really doesn't mean anything. So in selecting that next level of care, it's very important to ask what type of mental health services are available so that the client can continue to get that help that they need.
Thank you so much, Doctor. Just want to mention that yesterday in NJ.com there was a very comprehensive story on this particular issue, and in particular dealing with adolescent mental health services. So if you have an opportunity, it's a really interesting story to read, and talks very much of a similar situation as the doctor had described. Our next speaker, Alexa. Alexa, could you tell us a little bit about your journey in recovery and some of the positive and negative aspects of that journey?
Yeah, absolutely. Thank you guys so much for having me today. I'm a member of the South Jersey recovery community, but on top of that, I also work at All In Solutions Counseling Center in Cherry Hill, which is an intensive outpatient and outpatient substance abuse treatment center that deals with a ton of the issues that everybody has already touched on. So I think it's important to say that I am a product of 10 years worth of relapses. So it took me a really long time to get the amalgamation of services and components of recovery to sort of get to the place where I am now. So I think it's cool to look at me and say, look, she's done so well, but there was a lot of years where it was just relapse after relapse, 90 days, 6 months, 9 months, and falling back into the cycle again. I also have a co-occurring disorder. I have major depression, so it would get the substance abuse under wraps, and then the depression would come up, and then I would be like, well, I'm either gonna kill myself or use, so I would use, and the cycle continues and continues. So I would say the big barriers that I faced, the biggest being stigma. I should say I didn't recognize. My lovely mother, who's here today, recognized at a very young age that there was something going on, and got me into services right away. And I'm so grateful for that, because I'm 28 today and have 3 years in recovery, and I started trying. Thank you. But I started my recovery journey at an inpatient rehab at 16. So it was, I often think if that hadn't happened as soon as it had, I would be 38 or not alive if I hadn't started on this journey so early. But stigma is a big part of it, and lack of psychoeducation. So I think a lot of people associate, especially youth drug use, with like a rite of passage or just a phase. And of course, nobody wants to have an addict. No one wants to be an addict, right? So there's a lot of, she'll just grow out of it, or, this is just something she's going through right now. And addicts hit the worst parts of the worst characteristics. There's manipulation, there's lying, there's stealing. So I think it's easy to look at me and have empathy for me now, but if you knew me 3 years ago, you probably wouldn't want me around you. So another big thing is stabilization. That was like a big gap that I saw, and I still see in the work that I do today. Making sure that there are adequate treatment providers for when people are seeking help. And that's a huge gap that I see in treatment, and I saw in my own recovery. When people decide that they want to enter into recovery, whether that's medically assisted treatment, whether that's total abstinence, we need to be ready to strike when the iron's hot. And too often do we have people ready for help who can't receive services for 2 to 3 weeks, months, sometimes there's year waiting lists. So what that does is, the mind changes really quickly. And if you can't get what you need, all of a sudden you don't want help anymore. I see this specifically for clients that don't have private insurance, people on Medicaid. They cannot access the services so desperately needed to begin that journey to recovery. And asking an addict to wait a week for a bed in a rehab is basically, in most cases, signing a death warrant. And I would say, third, that empathy cannot be spared in the addict community. So I often hear a lot of, people say, it's so great that recovery is happening and it's so great that there's a recovery house, but not in my neighborhood. Please, it'll bring down the property values. And I get that. I mean, I can say for myself, I lived in a halfway house and I worked in a halfway house for a year, and 10 women gathered in the spirit of just trying to get sober. There wasn't as much drama as you would think. It was really like a collective coming together. But we tend to take our empathy in society at arm's length. So we want it to happen, but we don't want it near us. And we need to realize how we can be active parts of helping addicts in community by saying, I'm going to be an active participant in breaking the stigma, by saying, I'm going to support you. I want you in my community. I want to offer you help. We can't spare empathy anymore, or keep this crisis at an arm's length, because that means 4,000 deaths a year.
Thank you so much. Pastor Davis, how has the faith community in Camden responded in addressing the epidemic, the opiate epidemic? In particular, maybe some specific examples of programs that have been launched.
Thank you so very much for having me here today and be a part to add to the conversation. It became abundantly clear to me as a leader in the community that the drug epidemic was pervasive, widespread, impacting every sector of the community, whether we're talking Camden or where I live in Voorhees or Morristown. It really didn't have a barrier, and it really didn't remain within the normal constraints of socioeconomic backgrounds, as we've heard today. It affected people across the board, and I realized that we needed to get involved. And from a perspective of leveraging the assets of the Camden Dream Center, which is essentially a workforce development, technology, STEM, learning, enrichment type of environment where we work with families and kids to teach them skills that are aligned to the 21st century. And we realized that many of those students had parents who were incarcerated, and that we needed to incorporate a faith component, not just simply around addictions, but a whole plethora of human need, so that, and much like the organizations represented on the panel, that we're addressing in a holistic sense the need of families. So we've been involved where we come from in terms of initiating a program in addictions. We started with reentry. We've been involved with prisoner reentry for over 3 decades. and we discovered that the vast majority of those who are, as has been stated, who are incarcerated is a direct result of some way involvement with drugs. And so on a weekly basis, we transport, this goes back a few years now, inmates from a local halfway house called Hope Hall, and began to provide services to those inmates. And we opened it up to the community, and we brought in members of our church who champion this because they are formerly addicted people, both heroin and alcohol. And both of them had the disease in the most nasty way. I mean, they were totally in the streets and lived as indicated very irresponsibly. No one wanted to be around them. So to see their lives today, you would not have known that they were caught up with an addiction so severely. But anyway, they championed the program, and each week on a Wednesday, we hold a peer-to-peer session that has been extremely successful. So much so that I hate to use the term 100%. I always say 99.5% success rate, because what I have found that in the faith community, to the core of your question, is that our core competency is love. And love is the most powerful thing that you can give a person, I believe, who is caught up in something they don't want to be in. They don't want to be addicted to drugs. They want a high quality of life. But I find that, and we have found and discovered that in most instances, it was unattainable because of some other barrier that's going on in their lives. And so we give them love, and we give them a weekly class after the peer-to-peer session that addresses the development of faith, not religion. So when I say faith, I mean just resuscitating a baseline belief system that they could use to rise from the despair, the depression, and everything that's going on in their lives, so that they can begin to believe again, that I can do this again. One of the things that is very unique about a faith community is that we inspire faith. We inspire belief. And as a result of that, we have seen tremendous success and the layers and layers of issues that people have had in their lives. It's been my great privilege to experience removal of those barriers, to see individuals reintegrate safely back into society, become contributors of society, and reunified with their families in a healthy and successful way, and have a sense of their honor restored so that they become productive citizens. So to answer your question, from a faith community perspective, I think that because we are able to uniquely present the principles that are universally applied in the area of faith, enables one to regain a sense that they can believe in themselves and have hope and move their lives forward. And then once we work with our fellow, I don't call them clients, but we looked at them as sisters and brothers in our community, we recognize that we're not clinicians, that we're a community that works at the very grassroots level, and we refer them out to clinicians and experts who are either at the area where they could offer medications and housing and other resources that really are far beyond our purpose. So we understand our lane. We know that we're a faith community. We're absolute experts if you want to learn Python and coding and do some AI. We're great at that. That's what we do. But we realize that we can't teach your kid Python to create the technologies that's running the world today if the mother's on drugs and the father's in prison. So we had to adopt this holistic approach so that the Dream Center is totally separate from the faith community, separate 501c3. It functions independent of it. In fact, it's much larger than the church. The church is a small church here in Camden, but the leadership understood that in order to reach people where they hurt, that we needed to come out of we're not trying to religiousize a person. We're trying to pull them out of a condition that has really decimated their families and put them in a construct where we could begin to peel that onion layer by layer and then send them to the experts who can address the areas outside of our expertise, which is developing faith, and work with their children. I hope that helps.
Perfect. Thank you. Thank you, Pastor. We're going to go back to Dr. Salzman. Have you seen a change in the way doctors prescribe opioids, and also have you seen a change in the attitude of patients when they are being prescribed an opioid?
It's a great question. The answer is kind of sometimes. Again, a lot of what I do is driven by data. At Cooper, we took a hard look at opioid prescribing and tried to do a lot of education for our physicians and our other clinicians to kind of talk about safe opioid prescribing and how to talk with patients about safe and effective pain control. Shortly prior to leaving office, Governor Christie put some things in place that I think were well-intentioned, but didn't really achieve, I think, what he wanted to, unfortunately, and has created a culture of what some people are now calling opiophobia, right? Where some patients with underlying painful conditions now can't get access to medications that might be helpful for them. So it's a really delicate balance. And at the same time, when you look at studies done across the United States, we're still seeing upward trends or steady trends in opioid prescribing for conditions that really probably don't require opioids. So one study showed that there's been no change in one state, I think it was Alabama, for opioid prescriptions for ankle sprains, right? So, if you sprain your ankle, you can expect it to hurt, but it's going to hurt for a few days, and ice and NSAIDs like ibuprofen, acetaminophen are probably going to be adequate pain control, and yet prescribers continue to prescribe opioids. That's why my answer is kind of sometimes. There has been a little bit of change in patient attitudes where some patients come in and they are very clear that they don't want opioids. And sometimes that's okay, and I certainly understand that. But sometimes if a patient is having an acute traumatic injury, and I can give you another concrete example of a patient who had actually become stable on pharmacotherapy for his opioid use disorder, and then unfortunately was a victim of gun violence and was shot in the chest, and wound up in our trauma ICU. And he's telling the team, don't give me opioids, okay? But he just had, I won't get graphic, sorry. But he had a really big procedure, and I had to go to the room and say, you know what, it's okay. You're in a controlled environment. And this is a medication that's going to be helpful for you. And if your pain isn't controlled, you're actually at risk of a whole bunch of other medical complications of not having adequate analgesia. So it's a difficult balance. And one of the problems is that physicians and other care providers haven't really been afforded the time to have these difficult conversations with patients because of pressures to see more and more patients and reimbursement issues, time crunches, and sheer volume, right? So when we look at this kind of on a larger scale, the influences on physician practices are at times overwhelming and sometimes dictated by patient satisfaction scores. And if a patient comes into a practice and says, I need you to treat my pain, or they come into the hospital and they're asking for analgesia, and we want to have the time to talk with them about safe and responsible analgesia, but we also know we're at risk for not getting compensated for that visit, because if a patient's dissatisfied with their visit, then we don't get paid for that visit, or at least we don't get paid for some of that visit. So the external influences on care provider practice is actually really complicated. And that's why I think there's a little bit of a very slow trend in seeing changes in prescribing patterns, and also that alternative treatments for pain are hard to come by. Regional anesthesia with injections are really hard to get. Having access to interventional pain specialists is really, really hard. We have some great pain management experts who can do very complicated procedures for our patients, and they do really well, but getting in to see them can take months and months. And so the answer is that they're likely going to be continued on their opioid prescriptions. And we even know that long-term opioid prescribing for a lot of these chronic painful conditions like musculoskeletal back pain actually tend to make patients worse. But because they become so entrenched and oftentimes dependent, to try to switch them to other medications that are going to be arguably as effective and less dangerous becomes just really challenging. So it's a great question. It's a complicated question that probably goes beyond what I have time to talk about today, but there is some movement. We're doing a lot of education, a lot of outreach, both to our clinicians and to the community. Did that make sense?
Yes, thank you. Another part of that is the fact that in New Jersey, just recently, the state requires now that all prescribers must take at least 1 hour of a continuing medical education credit on safe prescribing. So it's a good way to, I think, to be able to at least introduce the subject in the medical community. For many years that wasn't taking place. Dr. Muir, you spoke about the poverty, violence, and trauma and other very important issues that the center addresses. How do these obstacles factor into the rise of the opiate epidemic, and how is the solution to the opiate epidemic and addiction intertwined with addressing these community problems?
Well, it does tend to be a bit of a vicious cycle. But like most circles, it doesn't really matter where you break into it. You need to break into it somewhere. So there's a lot of talk now about early childhood trauma experiences, the ACEs information that is out around the impact of early childhood trauma on later vulnerability to things like addiction, drug use. So there are a lot of programs that attempt to address childhood trauma, and most programs at this point, certainly really all programs that serve adults, need to be addressing trauma. At Center for Family Services, we have programs kind of contained within clusters. I'm over the substance use disorder programs. There's an entire other cluster of programs that are trauma services, and the person in charge of that is centered, in fact, here in Camden. Those programs attempt to address the trauma both at a community level, for instance, the Promise Neighborhood here in Camden, and on individual levels in treatment. So, for instance, all of our substance use programs have a trauma component to them that attempts to at least start to open the door. Don't forget, when somebody's coming into treatment with us, even though we might not be their first treatment experience, what they're going to get in treatment is typically beginning to address a very large iceberg that isn't going to get resolved inside of 12 weeks, even 6 months. It's going to be ongoing work for somebody in recovery to address the effects that trauma has had on their life. There are a variety of programs that begin with addressing family trauma, for instance, throughout New Jersey as a result of the substance abuse initiatives here in the state that came out of federal intervention with the Division of Children and Families. There are assessment people in every DCF office throughout the state that do assessments for substance use and other issues for someone with an open case. And then there is a referral to treatment. So the intention is to address the problem that the parent has at the same time that the child is getting protected. we're one of 3 agencies that provides that. We provide it throughout southern New Jersey. There are 2 other agencies in New Jersey that do it in the rest of the state. So that's one level that you start to see it at. Again, Promise Neighborhood addresses it at a neighborhood level. There are a variety, for instance, of residential units where children who have been traumatized at home and are in need of shelter can begin to address the effects of trauma and their own addiction. For instance, there are co-occurring homes for residential youth in New Jersey. It's now called Ascenda. It had been called Robin's Nest. Has one of those programs. Center for Family Service has another. And so there are a broad range of programs that seek to address the problems that can be created by trauma that then results in addiction. And if you don't address the trauma, even though you might address the addiction and somebody stays clean for a while, they then get re-triggered by the trauma, get back into their addictive patterns. So it doesn't matter where you really try to address the issue. The issues are all entwined with one another. And we need to remember that it's not going to get readily resolved within a short period of time. This is a long-term issue that people need to address.
Thank you, Doctor. Dr. Natal, can you discuss your work to implement the opiate overdose management trainings in substance abuse treatment facilities?
Sure. So my graduate project here at Rutgers University, I received my doctorate degree here, was on implementation of opioid overdose management training in substance abuse treatment facilities. And it started from, I actually spent a lot of time in treatment. I work about 40 hours a week between residential and outpatient substance abuse treatment. And I can say for sure that not a week went by that I didn't encounter someone who lost someone to an overdose. And it became overwhelming. So the thought became, how can I integrate this into education, and where I was at that point in my life with obtaining my degree and my capstone project. So I worked with my committee, Dr. Jackson and Dr. Lentz here at Rutgers, and that's when Narcan was just coming to. So at one point, Narcan was only something you could get in a hospital, and it was not available to citizens such as ourselves. And my thought was, oh, I'll go teach people about Narcan and where they can get it from. And my committee was like, nope, not enough, already being done. And I was like, okay, do some more research and come back to me. So that brought me to the point of recognizing that people who have had a period of sobriety are more susceptible to dying from an overdose than those who are just out using every day. And my research furthered, and it became those who are coming home from jail, those who are leaving a treatment facility, or those who are leaving a hospital stay for some reason unrelated. Now their tolerance is decreased. Their idea is, I'm going to continue using it, I'm going to use what I used before, and they're overdosing. So we tailored that to the clients leaving substance abuse treatment. And I can take it back to harm reduction again. For a long time, substance abuse treatment has been founded on abstinence base. That was just our thought process. You don't use, you stay clean, and you're in recovery. And so trying to bring that, I work with John Pellicane on my project, who is the Camden County Drug and Alcohol Director. And he said, Serena, this is going to be a hard sell. People in recovery and treatment that are teaching clients to stay clean don't want to say, but here's this Narcan kit in case you relapse and you overdose. So I developed the training using multiple resources from the state of New Jersey, the Department of Human Services, and I went into halfway houses, outpatient substance abuse treatment centers, and residential substance abuse treatment centers for both children, adolescents, and adults. And I taught the staff how to actually talk to the families, how to talk to the clients, how to obtain Narcan, how to bill for that session, because billing is a huge part of treatment. So most people don't want to take a lot of time to do something that they can't incorporate into what they're doing every day. How to obtain Narcan for free, and I got very good results, very, very good results. A lot of people were happy to have that information to be able to say to a client, even if it's not you, people surround themselves with like people. We want them to change people, places, and things, but you can't leave your brother if your brother's using. But to be in a position to save your brother if he presents in overdoses, and knowing how to do that was very important. So it came out very well. And I can say, I am hearing more people say, and the part of my psych evals, I asked, have you ever overdosed? Were you given Narcan? There's a lot of people now saying, my girlfriend Narcaned me. My mom Narcaned me. I got Narcan by the neighbor. I got Narcan by the bus driver. So it was very well received. Very
Thank
well.
you. Just about a month ago, the state did a free Narcan distribution, and about 30,000 residents from throughout the state participated in a Saturday morning getting access to Narcan from local pharmacies. So it was a very successful program. You were a pioneer in that effort. Alexa, you shared with your story today. Why is that important, and how does that really make a difference in the audience that are here and the audience that are participating by way of our live stream?
Sure. I think that it's so integral to have a face to recovery. I think, even though it's not the most reliable source of why we should get behind, helping addicts, it's always helpful to be able to humanize a face of addiction, right? And have me in front of you and say, okay, this girl seemed pretty nice. She seems like she's gotten, through it. It seems like someone we can get behind. But I also think the impact of community support and shedding stigma, you really don't understand the difference that it makes. And to go back to the comments that were made on trauma, if we're looking at community support in mitigating trauma responses and perpetuating the cycle, I'll use, for example, when 9/11 occurred, about a year later, they did a study, and 5% of the population of Manhattan had resounding PTSD symptoms after that, which is a very small fraction of Manhattan considering what happened. When they polled New Orleans about a year after Katrina had happened, 1/3 of the city had PTSD symptoms. The difference between New Orleans and New York is New York had a ton of support from the American people when that occurred. In New Orleans, there was not as much support from the government, from the people of America. So we're seeing when we treat people who are going through traumatic things, such as addiction, and we provide them with community support, we reduce their stigma, their isolation, and we give them a better chance at recovery. So non-addicts need to get on this train as much as those who are trying to obtain recovery as well. I see so many clients, myself, but I see a lot of clients come into my treatment center and say, I just need to get back to work. I need to get into the flow of society. I need to start making money again. And while that's obviously important, I need you to slow down and go find some people you can relate to. Because if you keep trying to go back to work and just go right back into the rat race and become normal again, you're going to isolate yourself in your home. You're going to be triggered. You're going to feel different, and you're going to go back to relapse. So when we can find a community of recovery with our families who are more psychoeducated, in 12-step programs, in smart recovery, in refuge, in medically assisted treatment, with a therapist, in group therapy, we are slowly chipping away at the idea that you are terminally unique, you are broken, you are flawed, and we are telling you we have resources for you, and we're here to help you. And I always tell my clients, and I know it to be true for myself, you will not recover alone. You won't. You need a lot of support. And we as a community need to be able to step up and say, we have that support ready for you.
Thank you so much. Before we go on to the question for the pastor, I just wanted to share, or maybe have the panel share, about the fact that medically assisted treatment solely without the support services and the counseling is really just, the medically assisted part is just one part of the whole picture for recovery. And maybe we can get someone to comment about, looking at the whole picture with medically assisted treatment, what other services are necessary for the especially with the research that has been completed. But do you want to share?
Okay. So I don't think anybody would dispute the fact that these resources are important. When you look at housing first programs for patients with mental illness, we know that getting patients into homes before starting medications actually is what makes patients better. And we're probably at the point where we don't even need to study it anymore because the studies that are out there are resoundingly positive. That hasn't been clearly studied to my knowledge for patients with substance use disorder, but housing is important. Addressing all of the social determinants of health are important. Acknowledging early childhood trauma, adverse childhood events are important. Unfortunately, the data that we're left with is that when you mandate somebody to go to these other services, they don't get better without medication. And actually those going to things like IOP, partial hospitalization programs, while these are good programs, have not been clearly shown to help patients when they're mandated to go, when they're getting medication, when they're getting pharmacotherapy. And right now, the evidence actually supports that pharmacotherapy is far and away the most important part of this treatment process. That's not to deny the importance of all of those other things. When you look at a country like Portugal, where they decriminalized or legalized all drugs and took all of the money that was being invested in criminalization, right, with jails and prisons and courts, and they took that money and they invested it in social services and government-sponsored jobs. Just about every data point that they looked at, there was one data point that didn't get better, but every other data point got better. So I'm not questioning it, but in the absence of pharmacotherapy, the patients probably aren't going to get better.
Next question for the pastor. You spoke about your peer-to-peer addiction and recovery support services. Is there any particular success story that you want to share with some of the individuals that participated and how it's impacted their lives?
Sure, and that would be the facilitators. I think first, let me say that there is an enormous opportunity out there for faith leaders because we're uniquely positioned in a community with a message that is designed to build hope, and hope is what many of the people that we've been talking about often lack. They want it, but they don't know how to grasp it. As a faith leader, the one area that I lack, and that is I've never been addicted. So those of us who are in a faith community, if we could just look at the communities that we serve and identify champions who's gone through this, who will embrace a vision to offer hope to those who are yet in the position that they once were, and structure it so that in each community of faith, there is an effective process that is very similar to the one that we have developed. I think it could be scaled. And in scaling a project like this, I believe if they connect with those who are the clinicians and the medical experts who track the data, I think as a community, incorporating all of these approaches would be a successful endeavor for the state of New Jersey. Now, back to the question regarding changed lives. The two champions that we have, their life is a miracle today. Absolute miracle. We did a study on the two, one with heroin and the other one with alcohol. And where they are today is just beyond one's imagination. Even for them, they could not really, even today, grasp how far they've gone in life. And it's because we did not denigrate or speak harmfully against the different approaches that we've heard today, but that we've incorporated them all. And what I did was gave them hope. I gave them love. Dr. King's, one of his most famous quotes is, "You can't serve the people if you don't love the people." And love is what you find in the community of faith of whatever persuasion it is. And I believe to not incorporate that in any of the processes discussed today will always come short. Because what we do is we address the inward need that all of us have, that if we persist, if we work hard to build aspiration for a higher more complete quality of life, we can attain it. And in order to do that, if I have to follow the directives of my medical doctor and my clinicians and my counselors, then so be it. So to connect all of that with, have the connecting tissue of an ecosystem that works collaboratively, I believe we can get there together.
Thank you, Pastor. So what we're going to be doing at this point is we have some questions that we received ahead of time from some of you here today. We have some that we received from our live stream audience, but also we have 2 microphones on either side of the room. If you'd like to ask a question, if you could just go up to the mic. This is being live streamed, so if you could speak right into the mic, that'd be helpful. And we're going to ask each of our panel to contribute to this conversation, whoever would like to participate. We'll start with one that we received from one of our live stream audience members. Every day on my walk to work, I see people suffering from addiction. I'm not sure what to do to help. And they go on to say that as a resident of Camden, how can I make a difference in addressing the opiate epidemic in my everyday life in my community? So somebody want to address that? Are there volunteer opportunities perhaps that might be available?
I'll speak on that a little bit. I think the number one thing is, does the person on the street want help? From my experience, it's very hard to render care to people who are not interested in help. I mean, someone spoke on the statistics about mandated treatment. So I think making a difference in your everyday life would not be so much as, handing out pamphlets on the street, though that would be great. The more resources, the better. But we'd be finding opportunities in your community to get involved in this conversation, such as this town hall. There's tons of nonprofits in the South Jersey area that support housing, treatment, resources for addicts. I can, King's Crusade, Stop the Heroin. I can think of 10 or 11 off the top of my head, and they always need volunteers and help. Whether that's, volunteering from your home from an email campaign or getting on the ground floor for an overdose awareness event. I would think really just volunteering your time, because it's not, as the doctor spoke on it earlier, we do need to think about, the ethical question of what happens when someone doesn't want help. And you will drive yourself insane trying to help someone who doesn't want help. So put that effort somewhere else.
Thank you. Yes.
Hi, thank you all. You were very helpful listening to everything you had to say. My question is more for Linda. So the state has put a lot of money into peer services. I mean, it's a huge effort. And I just wanted to talk would like to hear a little bit about how the peers are working as part of a treatment team in the ED. And just what happens after they're out of the emergency room, what goes on from there, and just what part peers play in that.
Well, certainly with regard to the current advocacy for peers, it's really started as a federal push. And I've worked in the field for about 35 years at this point. And I'm always interested to see what goes around comes around. This is a field that started really because people who were not very welcomed in some communities with regard to having their addictions looked at, treated, and their persons respected, basically had to come together themselves in order to support one another in getting help. And so you have 12-step communities that have sponsors who help their sponsees. And when there was not very much interest in dealing with the addict 40, 50 years ago, that same community basically came together and started a movement towards professionalizing a field that would treat addictions. And we got first CACs, and then we got CADCs. The alphabet just seems to keep on expanding. And it got so professionalized that it kind of lost sight of that kernel of truth that was there, that probably the best person to talk to somebody who is in the midst of an addiction is another person who has dealt with that same problem. And so we have come full circle and recognized that peers, recovery mentors, whatever it is you want to call that person, and there are different names, somewhat depending upon the funding source, seems to have a profound impact on somebody's initially deciding that they are going to reach their hand back out and accept the help that's being offered to them. So within emergency departments, this is part of the opioid overdose response program. It really is very much focused on a peer providing encouragement and support to somebody in addiction who otherwise would like to run the other way because they're terrified of withdrawal. They're terrified of the idea that they probably don't have the skills that they need in order to remain in recovery without using. And out of that has grown several other programs in the state. It begins in the emergency department, but it doesn't end there. That particular program can follow somebody for up to 4 months, up to 16 weeks now, post-emergency department. It's something of a challenge to stay in touch with people, particularly in the age of the cell phone. But that is the mandate of the program, is to stick with that person side by side with them as they try and negotiate early recovery, accessing services, et cetera. There's another program called the STORE program that can follow somebody up to a year with the same idea that it's a team of a peer specialist who's not a clinical person, provides encouragement, support. I've been there. I dug myself out of that hole. You can do it too. And a case manager to help the person actually access resources. But the peer specialist is a crucial person in helping somebody see that, as the Reverend mentioned, that there's hope in the situation, that it is not a hopeless situation. Again, that program can provide support for up to a year. What is up and coming in the field is that Medicaid is about to start paying for peer supports. Mm-hmm. And that is going to be a game changer because this has been a contracted service through the state that once it becomes paid for by Medicaid, with insurances kind of coming on board with that, we'll be able to provide more peer support in treatment than we currently have. Right now, it's kind of a bit of a disconnect. Most treatment agencies do not have peer supports. There are some that do, but most of this has been centered through some of these other programs. So it is a moving target, but it's also a growing aspect of how we're addressing addictions.
Thank you. Luis.
First of all, I want to commend Ms. Garvey for your success. It's very inspiring to hear your story. My question is inspired by Dr. Natal, the comment that you made between the relationship with substance abuse and mental illness. And the question is, this is an equal opportunity disorder from the literature that I read in preparing my comments today. Is there an opportunity for early identification of populations of children, adolescents that are at higher risk before they go down the rabbit hole of opiate addiction? And if so, how would we go about doing that? Thank you.
You're welcome. Thank you for your question. So I think that working with the youth, what we're looking at is a lot of those adverse events. So people have heard of the ACEs, and there are specific adverse events that we identify in children early on that put them at risk for a whole bunch of things later in life, not just substance abuse, but mental health disorders as well. Some of those things involve past trauma, whether it be physical or sexual abuse, or just hearing of a traumatic experience and being able to relate from an emotional standpoint. We have a lot of neglect adoption. We see a lot of that pass forward into substance abuse in later life. ADHD is a very interesting one. We often have parents say, if my child is ADHD and I give them a stimulant, is that going to turn them into a drug addict? And the research actually shows the opposite. It's the child who has never learned to control their impulses, who was diagnosed with ADHD, never given medication, who actually turns to substances later in life to try and help with that. So untreated ADHD is another one that we see. Grief and loss at a young age, losing a parent increases those chances of substance abuse or mental health per se, and then the co-occurring disorder in and of itself. You're welcome.
Thank you. We have a question on this side.
Good afternoon.
Hi.
Hi, good afternoon. My name is Angela Gonzalez, and I want to thank you for putting such an awesome hall here for us to learn and put those families that we work in contact with these services. My question is, could be either for Dr. Selman or Pastor Dave. I just wanted to, I hear about the statistics that are out there, how high these are. And in reference to recovery, I would like to know if there is any statistics for those programs that are of faith in reference to recovery. I work together with a group called the Coalition of Latino Leaders, and there is a faith group in there as well. And some of the questions that doesn't seem that they can find is the success rate of those programs. I just wanted to see if there was any statistics or if they have been taken into the consideration of the statistics to see their recovery rate of those participants that attend the faith program.
Well, from my experience, this is my 45th year in ministry, and I can tell you that I don't track data in this area, track data in other areas. I can tell you that those who come under our programming and commit to it, as I indicated in my comments, that the success rate is extraordinarily high. I don't like to say 100%, but it's way up, 95%, let's say. Not just for a moment, but continue, and then moving them into some form of leadership. And previously, we had a question regarding peer specialists. They become great peer specialists and on a volunteer basis, because again, we deal with the heart. I believe you mentioned empathy. See, love is a powerful thing. And one of the things that we lack throughout our society is people really love. I recently traveled internationally. I was in several countries, and I didn't find angry people till I got back to JFK. You know, so we have a love problem in our country, and so from a peer perspective, to work with professional organizations like what we see here with family services. Those are the kind of ecosystems that are in every community that we need to come together, so that it's not so much the faith community, but what is the impact of a faith community as it works along with, let's say, Rutgers University. We've been partnering with Rutgers University for many years in other areas, or Rowan University, or a virtual hospital system. So you can't look at a faith community independent of the other participants in human capital development within a community. So the way I see it is a new model of how faith communities arise and contribute to bringing healing and wellness back to the community. I'll say this and then stop. Think back several generations in each community. At the center of that community was a local house of faith. And most of the philosophy in terms of the ethics, the character, the norms, all permeated from those communities. Whereas today, we've left that the basis of basic character, integrity, honesty, and love, and we've gotten ourselves as a society way off base and out of track. And what's happening? Many of our people in our society are sick. And so what do we do? What do sick people do? They self-medicate today. And so we can just get back to including more faith component. And again, I don't have the statistics, but I believe the people who are much smarter than me, they're running those stats and doing those studies to determine just how effective it would be to have a faith community. Again, I say faith apart from religion. So we're not taking people and running them to the altar and casting demons out of them. That is not what we do. We're offering hope. We're inspiring so that that individual once again can see themselves as they once envisioned themselves to become something bigger and better in life.
Thank you. We have another question that came in by way of our live stream. As a parent, what should I do if my doctor or dentist prescribes an opiate to my child for a minor injury or a dental procedure? Is it okay to question a doctor and their alternatives in addressing pain for children at that level?
Yeah, as a parent, I would always encourage you to have that conversation with your treating physician, and you are always able to decline that prescription for your child. You're responsible for that minor, and you can say, thanks, but we're going to try ibuprofen, or what is the reasonable and safe approach to pain control for whatever this procedure is, and are there alternatives? I think that's a great question for any parent. And the data from the dental community is that there are lots and lots of prescriptions for opioid analgesics being provided, and often, and what we know is that when somebody is prescribed an opioid analgesic for at least, I think it's 6 or 7 days, the likelihood of that same patient being on an opioid prescription 6 months later is really high. So, what we talk, we want people who have pain to have good access to care, but we also want to prevent further dependence, right? So it's a great conversation to have about the duration of treatment, what is considered safe, and are there safer alternatives? So I would encourage everybody to have that conversation with their care provider.
Thank you. Next question.
Good morning. My name is Marion Jones, and I'm a Camden City resident. And I came here to get information, and I'd like to thank the panel. You've been very helpful with that. But I would like some clarification on something that Dr. Muir said, and it may sound like a stupid question, but I need it answered. You said that many of the people that come to your agency for help usually have no jobs, homes, or they have a low level of education. And I just wanted to understand whether that was because of their addiction, that they may have lost their homes, maybe their educational goals were diverted, or that they lost their jobs. Could you clarify that? And not just that they were homeless people or jobless people are using drugs.
I think that the point I was trying to make with
Doctor, would you mind just speaking into the mic? I'm sorry.
Thank you. I think that the point I'm trying to make with the information was kind of the change in these social determinants that we've seen over time as heroin use rose and the use of other drugs, the pattern shifted of what people are reporting as their primary drug of choice. So what seems to have happened is, with the increase in the report of opiates as being the drug of choice, we've seen this more significant impact, apparently, on their ability to maintain their independence, and whether that comes from an ability to hold a job, long-term effect. I don't know what the causative piece is, and it's probably multi-causal, right? But there seems to be a relationship, is what I'm trying to point out, and that the opiate use seems to have impacted the statistics regarding those social determinants more than the other drugs ever did. So that when you take a look at a period like around 2006, which was the earliest data I could get, and you saw alcohol and marijuana as being the most highly reported drugs of choice, with cocaine higher than heroin was, you don't see the same kind of numbers around the impact on homelessness, legal involvement, unemployment. I'm trying to remember some of the other numbers. You didn't see as big an impact as the opiate use apparently has had on those numbers. So what caused what? I don't think I'm in a position to say, but there's clearly some kind of a relationship going on. And certainly what we know is until you start to address the whole person, right, and all of those problems in some way, addressing just one of those problems is probably not going to have the kind of impact that paying attention to all their other needs will have on their being able to maintain, to achieve, and stay in some kind of long-term recovery. I'm not only concerned about am I getting them off of the opiates now for today. I'm concerned about their ability to go forth in the future and pull their life back together. These people seem to have more needs than, for instance, we saw in the crack epidemic, which that was kind of the beginning of my career. The needs are much greater with the opiate users for whatever reason.
Okay, thank you.
Thank you for that question. Yes, next.
First, I'd like to say thank you, all of you, for all the information. It definitely gave me another look at how I can help. My name is Ethel Wade. I'm the unit director at the Vineland Boys and Girls Club. Question I wanted to ask in dealing with this disease, how is law enforcement being helped? They are dealing with this in the street firsthand, and some of the things that I have witnessed, they are not really prepared and aware of what they should be doing. I don't know who can address that, but law enforcement, how can they be helped? How can they, and how can they help?
I can probably speak for the Narcan in and of itself, just in terms of how they're helping to help other people. They were amongst one of the first groups, of course, to receive that Narcan training when it became available to the community and not just something you could receive in a hospital setting. It first became available to first responders and the policemen themselves. The other thing in terms of helping them deal with it, because it is a traumatic experience. Alexa mentioned it's traumatic for the person with a substance use disorder to have a substance use disorder. It's traumatic for the first responders who, especially in cities and areas where the levels are a lot higher, to see this day in and day out, like you're literally seeing people die over and over and over again. I would refer back to the employee assistance program. They all should have, through their health insurance and through their employer, where they literally can call and receive supportive services to help them deal with some of that, because it is very difficult, very difficult.
Yeah.
Thank you.
And just to follow up, the partnership actually last year hosted the first ever law enforcement conference on the opiate epidemic. And it was a great opportunity for services at all different levels, the state level, the county level, and the community level, to share what resources are available to support law enforcement, because we do know that there is a lot of post-traumatic stress that's happening at that level as well. So thank you.
Hey, can I
Yeah, please,
one
Doctor.
comment to that?
Yes.
So I think the education and training for law enforcement and all pre-hospital care providers is very important, and I wanted to give I want to acknowledge we have some Cooper EMS folks here, and one of the things that we've done through Cooper is not law enforcement, but EMS services, who I think struggle with the same issues that you're talking about. And I think it's led to a lot of burnout and moral injury and shortened careers. But what we've done in working with our pre-hospital care providers is actually having them practice at the top of their licenses. And for those of you who don't know, we've actually initiated bringing buprenorphine out in the field for patients who want it, and then early referral to treatment services. And thus far, it's been a very effective program that was rolled out statewide, but I don't know that any other groups are doing it. But that kind of ongoing engagement and allowing providers to practice at the top of their licenses and let them see the impact that they're having on the patients in the community, I think can be very rewarding.
Excellent. Thank you, Doctor.
Thank you.
This will be the last question. Go ahead, please.
Good morning, well, almost afternoon, everyone. Thank you to all of the panelists and also to Rutgers for hosting this event, very needed and important. My name is Nafessa Wiggins. I'm a native of Camden, a Rutgers alum, social work major. I'm happy to be here on this morning. I just have two questions, and I'm going to sit down. One question is, can anyone speak to any of the outreach efforts that are possibly being made to address those in the city, right specifically in this area, for those that may venture out to downtown Camden City? You can see a lot of what opioids and additional other substances are doing to our people right here in the city. They're out there. I'm just wondering what's happening, what outreach efforts are being made to touch those people that are out there every day in that transportation center area, CVS, TD, the jail, that area on down Broadway. And then my second question is, if anyone can speak to what resources and supports are available for our adolescents through this initiative. I do work in the Camden City School District, and I'm always looking for supports for our adolescents who may not be at this stage utilizing opioids, but we know that a lot of our young people are using marijuana and other substances that lead to addictions, such as opioid usage. So anyone can speak to those two questions. I thank you greatly.
Thank you. Anyone like to speak to the question about either one?
I don't know it as well as I should because it's kind of over in another section of CFS, which is a 90 program agency, so I don't know all of them as well as I should. However, the agency does provide a lot of outreach in Camden City. Power Corps is one of those programs that seeks to go out into the street preventing violence and making an impact on gang membership and relationships in the community. In terms of adolescent use, I wanted to say I also know that we've got peer specialists who literally kind of on their own at times will go down to the train station and do sort of a personal outreach. There are other peer specialists who do that under the umbrella of the agency, but that's the level of commitment that some of the peer specialists have in this area that I don't think you find your average counselor taking something outside of their work week and going down to the transportation center and looking to see who they can help. So I've always found that a rather interesting aspect of the level of commitment of peer specialists. Adolescent. I started my career working in adolescent treatment and inpatient at a time when inpatient units were popping up right and left, dealing with what was the beginning of adolescent substance use in the early 80s. And a lot of that has gone by the wayside. It's very difficult at this point to get more than maybe about 10 days of inpatient treatment for an adolescent if that's the level of care that they need. We had a program in South Jersey, Daytop, that closed basically because you really couldn't get kids in to their services and they couldn't maintain that facility any longer. So what we're left with a lot is very short-term stuff for adolescents in terms of residential treatment. But there is a number of programs that are around that are intensive outpatient or outpatient level of care. We do some services in Camden ourselves, specifically to substance abuse, but a lot of other services for adolescents, not specific to substance abuse. SODAD is another agency that maintains adolescent services. Genesis Counseling, located in Collingswood and with several offices throughout the county. So it's mostly at the ambulatory level of care, not residential anymore, that you'll find services for adolescents. Very brief stays in terms of residential care and getting people back out into their community, back into their family, back into the few residential transition services that are available for adolescents. There is not as much out there as there needs to be for adolescents, probably because back in the 80s we got pretty discouraged about dealing with them. It's hard to produce good numbers when people go to do the research, and that was a lot of what closed down residential services at that point. So it's not that it's not needed, but having an impact and coming up with a program that is going to provide the kind of numbers that continue funding for that particular age group is very, very difficult. And anybody who has an adolescent at home knows how difficult it is to have a significant impact the first time around. And unfortunately, that's what a lot of the research looks for, is how quickly can you make an impact. And with an adolescent, you are talking about, for the average person, you're talking about 6 to 7 times in treatment before somebody gets the message. And we as a society do not have the patience for 6 or 7 times in treatment to show efficacy that says that this is worth sticking with. We are a society that back in the 60s spelled relief ROLAIDS. And we continue to do that. It's just that we use it with different drugs at this point, not Rolaids. We've gone well past Rolaids.
Yeah, thank you. There are some tables on both sides of the room with groups right here in Camden and the Camden County area that are providing services on a daily basis, and we would encourage everyone to please visit some of the exhibitors at the conclusion of the program. I understand we have an opportunity for one more question. We have with us Councilwoman Morton, who has a question that she'd like to address.
Yep, good afternoon to everyone. My name is Felicia Reyes Morton, Camden City Councilwoman, and I represent the Rutgers community. Just wanted to thank the Partnership for Drug-Free New Jersey and for the town hall, especially here in Camden City, which I consider patient X. And so I'm looking forward to the continued conversations. I think it is important to involve the local government system in these efforts, a more strategic plan and approach. And that just goes back to the fact of providing hope and love and support to the cause. And being able to have a centralized location for people to feel comfortable to come to and know that they'll receive all the information and resources that are available, to that specific cause. So, thank you again for coming and being here.
Thank you very much, Councilwoman. We have one final question for each of the panelists. What have you all learned from interacting with the audience today? And if any, is there a specific action item you might consider as a result of today's conversation? And we don't have to do it in any order. If anybody wants to begin, just please start the conversation.
Like I say, the numbers are staggering, and how they related it to what we're very familiar with, a stadium where the Eagles play, or the Twin Towers and things of that nature. I was not aware that the opioid scourge was as severe as it is. And so I benefited. What I'll do is to return to my team and pull together the team in order to think more in terms of how to strategically align ourselves with our existing partners so that we could perhaps formulate an appropriate response. So it's been very beneficial for me to have attended.
Thank you, Pastor.
I think that, hearing, I think sometimes when you're working on the front lines of like substance abuse treatment with clients face to face, it's easy to forget that there's a whole community that's also doing the same thing you're doing. So hearing that efforts from my colleagues up here and seeing the community that showed up today, it's good to know that we are tackling this as a community, and good to know that there are other resources available for me and my clients.
Thank you.
She took my answer.
That's okay.
But I agree. I actually work about 80 hours a week, so I'm always in it. And to be able to come out and take the time and see how many people in our community in different areas, whether it be community, people who just live in a community, or different providers, different agencies, the DEA, how many people are actually out dispelling this information in the community, and the response that's received makes me want to actually involve myself a little bit more and find that time to continue to do things like this to help other people.
Excellent.
Remember my microphone. I think as opposed to years ago, it is heartwarming to hear how many people want to be part of the solution and are realizing that you can't keep this at arm's length anymore. My own kids know kids who have died. My older son's best friend passed away a year ago of an overdose. We were recently looking for some property to do a program down in Salem County, which is where I live. And the owner of the property, which is a small business, told me that 3 of his employees in Salem County had relatives who had passed away from an overdose. So we don't have the luxury anymore of keeping things at arm's length, and it really is heartwarming to me to hear that people want to be involved. Almost every agency, whether it's the hospital, whether it's CFS, just about every agency I know has some kind of a volunteer arm to it. And people who want to get involved just need to call that agency and ask, what can I do to volunteer? It may not always be directly with substance abuse, but there are lots of ways to volunteer that are going to help somebody get their life back together.
Excellent. Thank you.
Yeah, and I would echo, I think it's amazing to have learned about all of the resources that are available for patients who want them, and that the community is prepared to have difficult conversations around these issues, and it's just an honor for me to be a part of the conversation.
Excellent. Well, let's give each of our panel a great round of applause. They did an outstanding job. And we want to thank each of you for being part of the conversation here today. We hope that today's discussion has inspired you to make a difference in Camden in dealing with this crucial fight that we're facing on a day-to-day basis. As a small note, we have provided each of you with a package of 25 handouts. We would encourage you to spread that message in your community by spending about 10 minutes just leaving these on front doors. It's giving people an opportunity to get better acquainted with the opiate epidemic and maybe identify services that might be available to help them or their loved ones. In conclusion, we want to just remind everyone to please hand in your evaluation form to be eligible for the Apple Watch. And we want to once again thank Horizon and Rutgers for their support in allowing us to be here, and of course our relationship with the DEA, which continues to grow and become a real model for the country. Thank you very much.